Good afternoon, one and all. Myself, Sudipta Roy, and today I am here to discuss about a CNS pharmacology topic, that is sedative and hypnotics. Before we begin, let us know about a sedative drug and a hypnotic drug. Now, sedatives are those drugs which suppresses excitement and calms the subject without inducing sleep, but to some extent drowsiness may be produced, whereas hypnotics are the drugs which induces and maintains the sleep, which is very much similar to that of the normal arousable sleep. So sedatives and hypnotics are both CNS depressant drugs, but they differ in their time action and dose action relationships. Now, let us take an example. Say diazepam. Now, diazepam belongs to the class of benzodiazepines. What are benzodiazepines and how they act? Now, this benzodiazepine group of drugs act by opening GABA A-mediated chloride channels. So, as soon as these chloride channels are opened, they causes hyperpolarization, that is CNS depression. Now, we have to see how this affects the dose of diazepam in the sedative and hypnotic action. At lower doses, diazepam shows only sedative action, whereas comparatively higher dose shows as hypnotic action of diazepam, and at further higher doses, it causes general anesthesia to the patient. Now, as the sedative and hypnotics are involved with the sleep and awaking pattern of the humans, first we have to know a bit about the wakefulness and sleep of humans. So in our previous class, we have already discussed about the sleep and wakefulness cycle. I had given you an audio on that. So we will just take a small recap on the portion. Now, humans sleep and awaken in a 24-hour cycle. We had already studied about that. That is called the circadian rhythm, and that is established by the hypothalamus, more specifically the suprachiasmatic nucleus of the hypothalamus. Now, the electroencephalogram recordings show that the cerebral cortex is very active during wakefulness. Fewer impulses arise during most stages of sleep. We had also studied about the reticular activating system, which is responsible for the arousal from sleep. Now, sleep is nothing but a state of altered consciousness or partial unconsciousness from which an individual can be aroused. So, sleep deprivation will obviously impair attention, learning and performances of humans. Now, sleep can be defined or can have two components. One is NREM sleep, one is REM sleep. NREM sleep is the non-rapid eye movement sleep, whereas REM sleep is the rapid eye movement sleep. Now, NREM sleep consists of 4 stages, stage 1, 2, 3 and 4. Stage 1 is the transition stage between wakefulness and sleep. Stage 2 is regarded as the light sleep and is the first stage of true sleep. Stage 3 is a period of moderately deep sleep, and stage 4 is the deepest level of sleep. Although brain metabolism decreases significantly at body temperature drops, most reflexes are intact and muscle tone is decreased very slightly during this stage 4 of NREM sleep. Typically, a person goes from stage 1 to 4 of NREM sleep in less than an hour. During a typical 7 to 8 hour sleep, there is 3 to 5 episodes of REM sleep, during which the eyes move rapidly back and forth under closed eyelids. REM and NREM sleep alternate throughout the night. REM periods, which occur approximately every 90 minutes, gradually lengthen until the final one lasts about 50 minutes. Now, this was about the REM and NREM sleep, which we had already discussed in our previous class. So, today let us begin with the classification of drugs. The very first class of drugs which acts as sedatives and hypnotics are the benzodiazepines. Now, benzodiazepines are widely classified into three groups. One is the hypnotic, one is the anti-anxiety drugs, and the third is the anticonvulsant drugs. Now, hypnotics, example of hypnotics are diazepam, alprazolam, lorazepam, nitrazepam. Anti-anxiety drugs include again diazepam, alprazolam. Apart from that, it also includes clonazepam and chlordiazepoxide. Anticonvulsant includes diazepam, clonazepam, and clobazam. Now, let us move on to the properties, mechanism of action, therapeutic uses, and ADR of these class of drugs, benzodiazepines. Benzodiazepines are selective CNS depressants that produce sedation and relieves anxiety, helps in producing sleep, suppresses seizures in epileptic patients, and also reduces the muscle tone. Now, diazepam and chlordiazepoxide were the first introduced benzodiazepines in the 1960s. Till then, benzodiazepines are the most widely used drugs in the treatment of insomnia, anti-anxiety, as anti-epileptics. Now, benzodiazepine class of drugs has already replaced barbiturate class of drugs because of its high therapeutic index and thus is a relatively safe drug. We have already discussed in our class regarding the therapeutic index and the safety margins of drugs. Now, obviously, we will prefer a drug which will have a wide safety and not a narrow safety ones like that of a barbiturate. Now, if only in case of intravenous injection of benzodiazepines, the blood pressure and cardiac contractility decreases. Hypnotic doses also do not affect the respiration or cardiovascular functions. Next, the most important feature of benzodiazepine is that it have lower abuse liability. Now, we obviously prefer drugs which can not be abused by individuals. Tolerance is also mild in this case, so the drug dose fixation will not be a problem. It has a high therapeutic index and high safety margin, so drugs does not produce adverse effect to that amount, and very less withdrawal syndromes are also marked. It also produces lower psychological and physical dependencies, which are a most important problem in case of barbiturates. Now, with that, let us move on to the site of action of benzodiazepines. Now, benzodiazepines act on CNS, no doubt, but the exact site of action of benzodiazepine is on the midbrain ascending reticular formation. And this reticular formation, as we have already studied, maintains wakefulness, as well as benzodiazepines act on the limbic system, which is responsible for thought and mental functions. Further, muscle relaxation is produced by a primary medullary site of action, and ataxia is due to action on the cerebellum. Here we can see we have a structure of the brain, and this is indicating the reticular formation. Now here you can see their reticular formation is being formed, and it moves on to this paths around the central nervous system. Now, this is followed by the mechanism of action of the benzodiazepines. Now, benzodiazepines act by enhancing both presynaptic as well as postsynaptic inhibitions. In which receptor does it act? It acts on GABA receptors, more specifically GABA A receptors. Now, we have already studied about GABA receptor. As we all know that GABA receptor has two forms or is present in two forms. One is GABA A receptor, another is GABA B receptor. Amongst these two, GABA A is a ligand-gated chloride channel receptor, and GABA B is a G protein coupled receptor. Now, GABA A is a ligand-gated ion channel receptor and is pentameric in structure. The pentamer is formed by alpha, beta and gamma units. It consists of 2 alpha, 2 beta and 1 gamma subunit, and is arranged in a circle around the pore in a sequence of alpha, beta and gamma, that is alternate positions. Now, benzodiazepines bind to the alpha gamma interface of the GABA A receptors. After binding to the alpha gamma interface of the GABA A receptors, it opens the chloride channels, and as we all know that the membrane potential of the chloride is usually negative to the resting membrane potential, it increases the chloride membrane permeability. Thus, the chloride increase hyperpolarizes the cell and reduces its excitability, finally causing a CNS depression. So this is the picture of the GABA A receptor, and here in this we can see that this is the alpha gamma interface, and see, this is called the BZD, that is benzodiazepine receptor area, where it gets bind to. And getting bind to this alpha gamma interface, it increases the opening of chloride channels, and thus chloride is being influxed into the intracellular side of the membrane, thus causing CNS depression. Now, in this chart, the various types of benzodiazepines depending upon the duration of action is given. That is, you can see the duration of actions, it can be depending upon the duration of action, it can be classified into ultra short acting, medium acting and long acting benzodiazepines. The ultra short ones are midazolam and zolpidem. Though zolpidem is not a benzodiazepine but acts in a similar manner. We will study about zolpidem later also. Short one is lorazepam, oxazepam, temazepam, etc. Medium acting benzodiazepines are alprazolam and nitrazepam. Long acting ones are diazepam, chlordiazepoxide, florazepam and clonazepam. The half-life of the parent compounds are indicated here, the active metabolite and the half-life of the metabolite along with the main uses. Now, if you look into the main uses, see, overall we can see the uses of benzodiazepines are as hypnotics, anxiolytics, antidepressants, muscle relaxants, anticonvulsants, etc. Now, if we look into the pharmacokinetics of benzodiazepine class of drugs, we see that benzodiazepines are well absorbed when given orally, and the peak plasma concentration is attained in about only 1 hour. The benzodiazepines like oxazepam, lorazepam bind strongly to the plasma proteins, and their high lipid solubility causes them to accumulate in the body fats. The benzodiazepine class of drugs are metabolized and secreted as glucuronide conjugates in the urine. They vary in their duration of action and may be divided into ultra-short, short, medium and long-acting compounds, as we have already seen in our previous slide. And the duration of action influences their use, the short-acting ones being used as hypnotics with reduced hangover, the long-active compounds being more useful as anxiolytics and anticonvulsant drugs. Now, the adverse drug reactions which are usually occurred with the use of benzodiazepines are that of weakness, blurring of vision. It causes dry mouth. The hypnotic doses causes dizziness, vertigo, amnesia, and it also prolongs the reaction time and impairs the psychomotor skills. The tolerance to the sedative effects also develops gradually. The withdrawal symptoms are very mild and may be intense in case of ultra-rapid elimination drugs. There are several drug interactions which occur with benzodiazepines. Now, the use of alcohol and other CNS depressants along with benzodiazepines may lead to excessive impairment, as all of them will depress the CNS, so it might or it will lead to a severe CNS depression. Concurrent use with sodium valproate, which is an anti-epileptic drug, has also provoked psychotic symptoms. Cimetidine, isoniazid and some oral contraceptive also have shown to retard the benzodiazepine metabolism. The therapeutic uses of benzodiazepines includes the reduction of muscle tone and coordination. Now, benzodiazepines reduce the muscle tone by a central action that is independent of their sedative effect. Increased muscle tone is a common feature of anxiety states in humans and may contribute to the aches and pains, including headache, which often trouble anxious patients. The relaxant effect of benzodiazepines may therefore be clinically useful. A reduction in muscle tone appears to be possible without appreciable loss of coordination. Clonazepam and diazepam are the benzodiazepines that have shown marked muscle relaxant properties. The second therapeutic use is sedation and induction of sleep by benzodiazepines. Now, benzodiazepines decrease the time taken to go to sleep, thus hasten the onset of sleep. They also increase the total duration of sleep, although the latter effect only in subjects who normally sleep for less than about 6 hours in night. On the basis of electroencephalogram, it is seen that benzodiazepines increase REM, that is rapid eye movement sleep, which is associated with dreaming, and slow wave sleep, which corresponds to the deepest level of sleep. Nitrazepam has shown to induce sleep and sedation. Benzodiazepines are often used as anti-anxiety drugs for treating acute anxiety states. For example, diazepam and chlordiazepoxide are widely used, but nowadays their use is declining because the recent studies are showing that antidepressants coupled with behavioral therapies are showing more effect than that of benzodiazepines. The last is the anticonvulsant activities. That is, benzodiazepines have anticonvulsant activities in individuals. Clonazepam, diazepam, nitrazepam, lorazepam are the various benzodiazepine class of drugs which have proved to have prominent anticonvulsant effects. Clonazepam, because of its selective anticonvulsant action, is used to treat epilepsy, as is diazepam, which is given intravenously to control life-threatening seizures in status epilepticus. Moving on to the next class of sedative hypnotic drugs, that is barbiturates. Now barbiturates are also classified again into three types depending upon their duration of action. The first one is ultra short acting, followed by short acting and long acting. Ultra short acting barbiturates are thiopentone and methotrexate. We have studied about thiopentone in the general anesthetic part. Short acting are pentobarbital and butobarbital, and long acting is phenobarbital. Of all these drugs, at present only thiopentone and phenobarbital is being used. Now, let us know a bit about barbiturates. Okay. Similar to benzodiazepines, barbiturates also act on GABA receptors, GABA A receptors, which are ligand-gated ion channel receptors, pentameric in structure, containing of 2 alpha, 2 beta and gamma subunit arranged around the central pore in the specific sequence of alpha, beta, gamma. Now, the site of binding of benzodiazepines and barbiturates differ. That is, benzodiazepines, we have just studied, it binds to the alpha gamma interface, whereas barbiturates bind to the alpha beta interface of GABA A receptors. Now, after binding, it facilitates chloride ions, which are negative ions, to get influxed into the cell and finally hyperpolarizes the cell. Barbiturates potentiate GABAergic inhibition by increasing the lifetime of chloride channel opening induced by GABA, whereas benzodiazepines increases in the frequency of GABA channel opening. That is, benzodiazepines increase the number of times the channel opens and barbiturates increases the time of the chloride channel opening and thus causing chloride influx into the cells, thus hyperpolarizing them. Now, barbiturates are also CNS depressants like that of benzodiazepines and produces dose-dependent effects like sedation, that will be followed by sleep, followed by anesthesia, followed by coma. Now, sedative doses given at daytime may produce drowsiness, may reduce anxiety as well as excitability. Hypnotic doses, if given, they shorten the time taken to fall asleep, that is, the person will fall asleep more rapidly and increase the sleep duration. The night awakenings will also be reduced. Barbiturates also have anticonvulsant activities. The site of action for barbiturates are, barbiturates depresses overall CNS, but more specifically the reticular activating system, which is the most sensitive of all the other areas, and its depression is primarily responsible for inability to maintain wakefulness. That is, a person will fall asleep within no time. Drugs used are phenobarbital and thiopentone sodium. Now, phenobarbital or phenobarbital was one of the first barbiturates that was developed and has shown anti-epileptic properties, which was recognized in the year 1912. It is well absorbed and about 50% of the drug is bound to plasma albumin. Half-life of the drug is 50 to 140 hour, and that is why it is a long-acting barbiturate. 25% is excreted unchanged in urine, and the rest 75% is metabolized mainly by oxidation and conjugation reactions. Now, thiopentone sodium, thiopentone, the free acid is insoluble in water, and thus thiopentone is given as the sodium salt. It also has a high lipid solubility, and that allows it to cross the blood-brain barrier. The undissociated form has very high lipid solubility and accounts for the speed of onset of action. If we look into the overall pharmacokinetics of barbiturates, we find that barbiturates are well absorbed from the GI tract, and lipid soluble barbiturates like thiopentone has instantaneous entry into the CNS, whereas which are low lipid soluble takes longer time. Redistribution also occurs in cases of highly lipid soluble drugs. The T-half ranges from 12 to 40 hours with drugs having intermediate lipid solubility. Barbiturates with low lipid solubility are significantly excreted unchanged in the urine. There are several adverse drug reactions of barbiturates, and due to these adverse drug reactions, nowadays their use is very much limited to general anesthetics and anti-epileptic drugs. We have studied about idiosyncrasy while studying the adverse drug reactions, type B adverse drug reactions. Now, idiosyncrasy, this is also an idiosyncratic reaction of barbiturate, that it may cause occasional excitement in some patients. Barbiturates are known to cause CNS depression, but in some individuals causes excitement. Hangovers are the common in case of barbiturates when used as hypnotics. Repeated use may accumulate in the body and may produce tolerance and dependence, and thus is a abuse liability drug, because physical dependence also occurs as well as psychological dependence occurs. Now, overdose of barbiturates may cause acute barbiturate poisonings. This may be suicidal or sometimes accidental. It causes excessive CNS depression. The patient or the person feels flabby and comatose, and the respiration decreases. Blood pressure decreases, cardiovascular collapse occurs, and renal shutdown is also seen in patients undergoing acute barbiturate poisonings. There are various pulmonary complications in the patients. The lethal dose depends upon lipid solubility. For more lipid soluble agents like short-acting barbiturates, it is 2 to 3 gram, whereas for less lipid soluble agents, it is 5 to 10 gram. The treatment for acute barbiturate poisoning involves gastric lavage, that is, give a suspension of activated charcoal in the stomach to prevent absorption of the drug from intestines. This may be followed by some supportive measures such as patent airways, assisted respiration, oxygen, maintenance of blood volume by infusion, and the use of vasopressors. Alkaline diuresis may also be done with sodium bicarbonate with or without mannitol, and this alkaline diuresis is very much helpful in the case of long-acting barbiturates, which are eliminated primarily by renal excretion. The last one is hemodialysis and hemoperfusion through a column of activated charcoal and other adsorbents, and these are effective in removing long-acting as well as short-acting barbiturates. There are several drug interactions of barbiturates as we have studied for benzodiazepines. Now, barbiturates have additive action with other CNS depressants similar to that of benzodiazepines like alcohols, opioids, etc. Sodium valproate increases the plasma concentration of phenobarbital. Now, phenobarbital also decreases absorption of antifungal drug griseofulvin from the gastrointestinal tract. Barbiturates are also known to induce several cytochrome P450 isoenzymes, including glucuronide transferase, and increase the metabolism of various drugs and reduce their effectiveness, like warfarin, steroids, griseofulvin, chloramphenicol, and many more. The therapeutic uses, as we have already told a number of times, that they are only used in two cases. One is for anticonvulsant therapy, another is as a general anesthetic. Phenobarbital and thiopentone are the drugs which are used as anticonvulsant and general anesthetic. Except for these two drugs, no other barbiturates are used at present. The next classes of sedatives and hypnotics are non-benzodiazepines and other hypnotics. Non-benzodiazepines include zolpicone, zolpidem, etiosolam, and zaleplon. Other hypnotics involve melatonin, tricloflos, and suvorexant. Non-benzodiazepine hypnotics are the hypnotics that are chemically different from that of benzodiazepines but act as agonists on specific subset of benzodiazepine receptors. Amongst this, zolpiclone is the first of the non-benzodiazepine hypnotics and act as agonist of benzodiazepine receptor and is involved in hypnotic action. The effect of sleep resemble to that of benzodiazepine. They do not alter REM sleep but prolongs stages 3 and 4 of NREM sleep. The T-half of zolpiclone is 5 to 6 hours and is indicated for short-term treatment of insomnias. The various side effects of zolpiclone are that of metallic and bitter aftertaste, impaired judgment and alertness, psychological disturbances, dry mouth, and milder dependence. The next drug of this class is zolpidem. Zolpidem is also non-structurally similar to benzodiazepines but acts on benzodiazepine receptors and shows hypnotic effect. The sleep latency is shortened, the sleep durations are prolonged in insomnias, like REM sleep suppression is slight in this case. The zolpidem is nearly metabolized in liver, the T-half is 2 hours and has a very short duration of action. It is also indicated for short-term use in insomnia patients as well as for patients having intermittent awakenings. They have a very few side effects and in most patients the side effects are not ever seen. Next is zaleplon. Zaleplon is the shortest acting of the newer non-benzodiazepine hypnotics. They are also limited to 1 or 2 weeks and do not ever develop tolerance or dependence. It is rapidly absorbed. The oral bioavailability is about 30%. No active metabolite is produced in this case. It is effective in sleep onset insomnias and do not prolong total sleep time or reduce the number of awakenings. This is followed by another non-benzodiazepine, that is etizolam. Etizolam also is a benzodiazepine analog and produces the full range of benzodiazepine actions like anxiolytic, hypnotic, anticonvulsant, and muscle relaxant properties. It is absorbed rapidly and the peak level is produced in 0.5 to 2 hours with a T-half of 3.5 hours. But chronic intake of etizolam may produce tolerance and dependence, and it carries abuse potential. Etizolam is indicated for short-term management of anxiety, panic, and sleep disorders. Now, the last class of sedative hypnotic drugs are some other hypnotics, that is melatonin, tricloflos, and suvorexant. Melatonin is the principal hormone of the pineal gland and is secreted at night and has been found to play an important role in synchronizing the sleep wakefulness with the circadian rhythm. The three classes of melatonin receptors are MT1, 2 and 3, which are found in various regions of the human brain and more consistently present in the suprachiasmatic nucleus of the hypothalamus and the pars tuberalis of the anterior pituitary. MT1 and 2 are G-protein coupled receptors and believed to carry out the function of facilitating sleep onset and fixing its timing in relationship to the circadian clock. Started ingestion of melatonin 0.1 to 0.3 milligram during daytime, which increase the circulating melatonin levels in healthy human subjects. Started before the flight, it has been shown to reduce jet lag symptoms in case of intercontinental travelers. Elderly insomniacs have reported subjective improvement in sleep quality. However, melatonin is not a dependable hypnotic, especially in non-elderly insomniacs. The next drug of this group is tricloflos, and this is an old CNS depressant which is a melatonin agonist and is used in insomnia and is an anxiolytic drug. Gastric irritation and abdominal side effects are milder in case of tricloflos. It acts in 30 minutes and its action lasts for 6 to 8 hours. It is sometimes used to sedate children in distress and rarely used in adults. The last drug is suvorexant, and suvorexant also promotes sleep by binding with the neuropeptides called oxyrins, which are found in the lateral hypothalamus and promote wakefulness by acting on oxyrin 1 and 2 subtypes of its receptors. In case of suvorexant using patients, the elderly patients are more prone to adverse effects like muscle weakness, abnormal dreams, and headaches, and patients with depression may also worsen if administered with this hypnotic suvorexant. So, this was all about the explanatory mechanism of actions, therapeutic uses, and the pharmacological activities, pharmacokinetics of various sedative hypnotic classes of drugs. I hope this video benefits you and look forward for another interesting video from the CNS Pharmacology. Thank you for watching. Thank you for your time. Thank you all.